طيب دكتور محمد، أنا عرفت عنك من قبل الشباب بالمجموعة. طبعا دكتور محمد خشمان، يعني أخ وصديق عزيز وقريب إلي. هو Associate Professor بجامعة ألاباما، رئيس قسم الجي آي أونكولوجي بالجامعة. كثير يعني مبسوط إنه رح يكون معنا اليوم ويعطينا من علمه. تفضل يا محمد.
شكرا يا بلال على الاستضافة، وصباح الخير للي عندهم الصبح ومساء الخير للإخوان والأهل بسوريا. أنا جدا سعيد إنه يعني صديقي وأخوي بلال حكى لي إنه أحكي عن سرطان البنكرياس عشان هذا الديزيز، يعني واحد من الكانسرز اللي عن جد صعب نعالجها، وبنفس الوقت يعني ما كان في نجاح باهر بعلاجها خلال السنوات الطويلة. بس رح أحاول بهالمحاضرة أحكي زي قصة يعني عن البنكرياس، شو التاريخ تبعه، شو عم نعرف عنه هلا، وإيش رح يصير بالمستقبل أو إيش ممكن يصير بالمستقبل إن شاء الله. طيب، يعني from an epidemiological point of view, pancreas cancer, it's responsible for many new cases in the United States. If you look here, يعني برجال, it is one of the relatively common cancers, وكمان نفس الوقت in women. But the striking feature that يعني اللي بدي إياكم تشوفوه من هذا السلايد إنه pancreas cancer is not one of the top common cancers. يعني هو مش رقم 1 ولا 2 ولا 3، بس بنفس الوقت when it comes to mortality، يعني how deadly قديش قاتل هذا الكانسر، it is very lethal. In men and women هو the 4th most common cancer cause of death. Because of this, سرطان البنكرياس يعني بيدعوا للناس انهم يتعاطفوا معه، لانه even though it's not common or not one of the commonest one like the prostate, lung or the breast, but when it comes in how lethal this cancer is, it is relatively lethal. That's why there is so much effort to treat this cancer. هلا كمان also يعني عشان نعرف قديش قاتل هذا الكانسر. It was really disappointing for the past many years. هذا السلايد بيحكي عن 5-year survival by stage at diagnosis of patients with pancreatic cancer, according to the American Cancer Society. High data was obtained for patients treated and diagnosed between 2009 and 2015. فأكيد هذا does not reflect the last 7 years of data that we have for patients with pancreatic cancer. But if you look, patients with localized cancer, meaning إنه لما يكون الكانسر just بالpancreas, which is a minority of patients, بس 10% من patients بيكون عندهم localized pancreatic cancer. The 5-year survival is 37%, almost 1/3, يعني ثلث هذول المرضى وضلهم عايشين لبعد 5 سنوات. Now, the time in the cancer, it goes to lymph node and become regional, which constitute almost 1/3 of the patients with pancreatic cancer. Of those, the 5-year survival is 12%. It's a significant drop between 37% to 12%. And obviously, it's very disappointing, once the cancer spread to go to distant organ, which more than 50% of the patients are diagnosed with pancreatic cancer when it is stage 4. لما بيكون راح على distant organs, the 5-year survival, it goes down all the way to 3%. The message from this slide, until maybe 2 years ago, the all stages together, يعني لو حطيتهم كلهم مع بعض, localized, regional, distant, pancreatic cancer, the 5-year survival was 9%. فأنا if I see in my patient 100 patients with pancreatic cancer هلا in 2022, assuming إنه هاي الداتا اللي هلا it applies, بس أكيد هلا الداتا شوية أفضل. After 5 years, لكل stages, 9% of those patients would still be alive, which is really disappointing. يعني أنت you put so much effort, not just for me as a physician, but also for patients. Now, the light of the tunnel, the light at the end of the tunnel, إنه PanCan it's an organization بأمريكا. They looked at 5-year survival rate for pancreatic cancer, and they analyzed data بعد 2009 to 2015, and finally it became 10%. فهلا صار double digit، يعني 9% هي يعني 1 digit، يعني رقم واحد. ال 10% اللي صارت رقمين. فيعني this is at least promising إنه يعني we have had some progress with pancreatic cancer. بس هلا بهاي الليكتشر أنا بدي أعطيكم يعني شوية more optimistic view. بس يعني the first 2 slides, this slide و this slide, just to really get your passion عشان يعني عن جد تتعاطفوا مع البنكرياس cancer. هلا one major update أحكي لكم إياه هون هو بالadjuvant treatment for pancreatic cancer. هدول الأطباء اللي عم بيعالجوا pancreatic cancer، المريض if the patient had surgery, Whipple ولا other type of surgeries to remove the pancreatic cancer. In the past, we have struggled بالضبط إيش ال best adjuvant treatment. We have a ton of literature تحكي عن multiple modalities of treatment. بس gemcitabine chemotherapy continue to be relatively acceptable standard of care. شو يعني هالحكي؟ إنه ضلهم يغيروا ويعملوا أشياء مختلفة بس ما تفوقوا جدا على الجيمسايتابين. في ترايل اسمها لسه رح يجي كمان شوي، بس هي جيمسايتابين مع كيبسايتابين. هاي شوية يعني it showed شوية improvement compared للجيمسايتابين. بس when this trial was designed, gemcitabine can standard of care. عشان هيك patients with pancreatic cancer who had surgery, they were randomized لفولفيريناكس أو هون they modified it, صار modified FOLFIRINOX against gemcitabine. And this is really was a landmark, pivotal, practice-changing trials. يعني so much يعني طبعا عم بقرأ المسجات، رح أكمل بالهاي. ما لما هاي الترايل was published, it was يعني a source of optimism. To say it in a different way, if you have a patient with pancreatic cancer and the patient can be treated with modified FOLFIRINOX, this is really the right thing to do. When this paper was analyzed, the median overall survival was 54 months against 35 months. So if you have a patient with pancreatic cancer that was resected, really with this trial that was published back in 2018, it really changed the practice to have modified FOLFIRINOX, the standard of care for patients with resected pancreatic cancer. Now, the historic 5-year survival, هدول المرضى اللي قبل شوي I showed you, was 37%, which correspond to 35, which just give you an idea. One-third of the patient can alive at 5 years survival. لسه لهاي study we don't have 5-year overall survival. But the median OS when this paper was published, 5-year survival was not present. The median OS survival was 54 months versus 35 months. Okay, this is just to give you one highlight, which the message from this slide that I want to share with you is, if you have a patient with pancreatic cancer that was resected, really the ideal choice of treatment for adjuvant chemotherapy, if it's available and the patient can tolerate this, would be modified FOLFIRINOX. And the treatment milestones. This is really a nice story. This is really one of my favorite slides that I have prepared to show you really the story of treating patients with pancreatic cancer. If you look, in 1940, the treatment for pancreatic cancer كانت surgery. Again, it depends on the location of the pancreas. If you have the pancreas cancer, the head of the pancreas, the treatment is Whipple surgery, which is a very complex operation, pancreatoduodenectomy. But though pancreas can, at a different location, sometimes we can get by different types of surgical operation that's not as aggressive as Whipple surgery. But in 1940, imagine, this was what, 80 years ago. This is when the first treatment for pancreatic cancer really was put together when it came to surgery. At that time, ما كان في chemotherapy. So after this, the 5-FU leucovorin over time have been used to treat patients with pancreatic cancer, but really with very, very limited success. Fast forward all the way, imagine dish سنوات بعدها. In 1996, this is when gemcitabine was approved and became the standard of care for patients with stage 4 pancreatic cancer as a treatment of choice. Imagine 1996. Now, how much progress did we accomplish over time? In 2007, they added erlotinib to gemcitabine. This is a nice story. Erlotinib is an EGFR inhibitor. When it was added to gemcitabine, it really improved. It led to statistically significant improvement. But the difference can a third of a month, almost any 10 days. Even though statistically speaking, it was significant. السؤال اللي كان بيطرح نفسه لcancer physician، هل هذا is this clinically meaningful؟ هل هذا يعني له معنى سريري للمريض؟ يعني أنت ممكن تعطي دواء ثاني للمريض عشان as an average to get 10 more days. أكيد بس for some patients it may give more benefit, for some patients it may not. بس the median or the average improvement no. 10 days. Sorry في سؤال؟
لا بس كنت عم جاوبك، اني كنت سألت سؤال انه في اهمية سريرية، كنت عم بقول لك انه لا بس ممكن statistically بس.
ممتاز يعني هذا معظم الأطباء بيوافقوك على الرأي. يعني أنا بعيادتي I don't really use erlotinib. بعدين لو في أسئلة ممكن أحكي لكم situations where I can use it. بس statistical significance is one thing, بس clinically meaningful difference is a different thing. And you already أنت حكيت إنه هذا بالنسبة لك ما بيكون بيعني شيء كثير. فهذا الإرلاتينib and gemcitabine. هلا ب 2011 this was a really good year. This is when FOLFIRINOX، أنا حكيت لكم قبل شوي بالadjuvant treatment المعرفة على FOLFIRINOX. الفولفيرينوكس ستوري بلشت بال 2011 by French group. وهم بلشوا الفولفيرينوكس ب patients with pancreatic cancer. وهذاك الوقت they compared it لجمسايدين وفولفيرينوكس became really the preferred first-line therapy for patients with pancreatic cancer. FOLFIRINOX اللي may not be familiar with هو fluorouracil. أنا بحب أحكي بالabbreviation FOL it stands for folinic acid. هو fancy folic acid leucovorin. الF اللي بعدين بتكون هي 5-FU fluorouracil. IRI-N irinotecan والOX oxaliplatin. So if you put them all together هذا بيكون 5-FU مع leucovorin, irinotecan, oxaliplatin. So three drugs مع helper. The leucovorin it helps the 5-FU to work better. This is the story of FOLFIRINOX. But it took from 2011 to 2018 when FOLFIRINOX became part of the adjuvant treatment. It took that amount of time. But in 2011, this was a really terrific year for pancreatic cancer when FOLFIRINOX was approved to be the preferred agent for first-line treatment for patients who can tolerate it and also when it's available. And in 2013, this is when we had another combination called nab-paclitaxel or Abraxane plus gemcitabine. So here they added nab-paclitaxel or Abraxane to gemcitabine, and again it showed it's superior to gemcitabine. عشان هيك it became also a second or alternative first-line treatment option. So if I have a patient in my clinic when I want to give first-line option, I usually pick between either FOLFIRINOX or Abraxane. So if you look, all of this really has been in the first-line therapy category. Now, in 2016, they genetic or they engineered irinotecan and made it called liposomal irinotecan. It's really, they made irinotecan more lipid soluble, so it can go through the lipids and maybe penetrate through tissue to get to the pancreas with 5-FU leucovorin. This combination was studied in subsequent lines of treatment, not first line, which is actually the first and I believe only second line agent that has shown survival benefits, statistically speaking, and also clinically meaningful difference. So now for patients who you have treated them with first line treatment, you could use liposomal irinotecan 5-FU leucovorin as a second line agent. هلا beyond 2016 هلا رح تشوف there's some disappointment but also some interesting things. There was no drug that was approved for all patients. So I want to make a distinction from 1940 to 2016, assuming your patient can be treated يعني هو الperformance تبعه good organ function adequate, any kidney function, liver function, all of this. Those treatments, you can give them to any patients. You don't have to have selection. But since 2016, pretty much every single treatment that I'm going to walk you through now, it cannot be applied to everyone. It has to be very selective. And what I mean by this, in pancreatic cancer, it's really not one entity. Pancreatic cancer is actually a very heterogeneous group. Let's explain. So 2017, if you have a patient with MSI high tumor, so if you check for macrosatellite instability and the patient is microsatellite unstable, or MSI high tumor, then pembrolizumab was approved in agnostic way, and it can treat patients with pancreatic cancer. But it's only the MSI high tumor. Now, 2018, there's a drug called larotrectinib, and this drug was approved in patients with TRK fusion. So you have to have TRK fusion. And then 2019, another TRK fusion inhibitor came to the market. It's called entrectinib. I'll talk to you through all of those in a second. And in 2019, olaparib as maintenance treatment. Olaparib is PARP inhibitor. And then in 2020, we kind of made an interesting change. We've combined GEM and CIS with vilaparib, plus minus vilaparib, in patients with germline BRCA1, BRCA2, PALB2 mutation. And here, really, the PARP inhibitor did not show any benefits. But I'll walk you through this data. This is just to show you kind of like the story of everything, but I'll walk you through the details in subsequent slides. And then 2021, now we have a NRG1 fusion inhibitor, and also we have two KRAS G12C inhibitor. So really the point that I wanted to mention now, from 2016 all the way to 2021, we have not had a single drug that you can give it to every patient. So you have to know the subtype or the group of patients that you're treating. Now, the disappointing aspect is this. What's the percentage of MSI high? It's less than 2%. So of all the patients you treat, you have to identify those 2%. I have been treating pancreatic cancer now for so many years. I have yet to find one MSI high pancreatic cancer. It's very difficult to find, but if you find, then you would have pembro. I'm going to ask a question, maybe make it more interactive. Does anyone have an idea of the incidence of TRK fusion in pancreatic cancer? Just a guess.
5%?
No, it's actually less than 1%. So it's extremely rare. Now, I have found one patient with pancreatic cancer with TRK fusion. Guess what? That patient, I can tell you a story later on, did really good with treatment. But imagine, so you have to test 100 patients, or ideally more than 100 patients, to potentially identify one patient with TRK fusion. So, but again, if you don't test, ما راح تلاقي. Okay, then the next question is germline BRCA1, BRCA2, and PALB2 mutation. Do you know what's the incidence? Just a guess.
Also 5%.
Well, it's actually 5 to 9%. So BRCA2 is the main one, but BRCA1, BRCA2, and PALB2 mutation, 5 to 9%. Now, I have seen many patients in my clinic with BRCA1, BRCA2, and PALB2 mutation. Now, the BRCA1, BRCA2, and PALB2, those are DNA repair, DNA repair damage mutations. So you need to put patients on platinum agent. That's why you either do FOLFIRINOX followed by olaparib, or GemCis. Cisplatin is a platinum agent. Now, anyone have an idea of the NRG1 fusion? How prevalent, or what's the incidence of NRG1 fusion?
I think less than 2%.
Less than how much, sorry? 2%,
less than 2%.
Okay, well, it's actually 0.5%. So you're close. Less than 2% is correct. One time I asked a question, and one person told me less than 99%, which is true, but it's really like not the most accurate answer. But now, what's that KRAS G12C mutation? Does anyone know the incidence?
كيراز بيكون ميوتنت ب 90% من المرضى.
But just to clarify, so there are many types of KRAS mutation. So we have G12D, G13D, G12V, G12G, R. I'm asking about the KRAS G12C. What's the incidence of the KRAS G12C?
Maybe it's rare.
Yeah, what's the incidence?
1 to 3%.
You're close, 1.5%. But again, those percentage, I mean, if you look at other papers, you may have slightly different percentages. But the bottom line is, if you add all of this together, you're really talking about the last 6 years or 7 years of our all efforts have only been successful in what, 10, 15% of patients with pancreatic cancer, right? We have not had a drug that would apply to all patients with pancreatic cancer. So that's, in my opinion, that's very important. When I see patients in my clinic, they come to me sometimes for a second opinion. They've already treated with FOLFIRINOX or gemabraxine. And I tell them, okay, let me do this molecular profiling to look for those alterations. I tell them, just to be honest, the chances of me to find something, it's very slim, but it's there, right? Especially if they have been tested for BRCA1, 2, and PALB2 mutation. But guess what? If you find one of those mutations, then really you would have great medications to really address patients with. Okay, so I think that's just kind of like give you a real story of how things started back in 1940 and what we're doing now in 2021. And I look forward for this to continue to change over time. Any questions on this slide before I move forward? Okay. So I'm going to walk you through exactly what I've mentioned here. So this is FOLFIRINOX. FOLFIRINOX, this was back in 2011. FOLFIRINOX was studied against gemcitabine, which at that time was acceptable standard of care for first-line treatment for patients with stage 4 disease. And if you look here, clearly FOLFIRINOX was superior to gemcitabine. So the hazard ratio is 0.57, and it was statistically significant. Also, it was clinically meaningful because the difference in median OS was 11.1 months versus 6.8 months. Again, for you, I'm going to say a few comments that I use on my clinic. So patients who are diagnosed with pancreatic cancer, a lot of time they come to my clinic and guess what? They will be told, oh, you have 3 months or 6 months to live. And because of this, they get anxious, they get scared, and obviously they come to see me a lot of time for second opinion. The way I approach this is I would tell them, in 2011, when we did not have much of the progress that I've showed you in the previous slide, the average person that was able to be treated with FOLFIRINOX, the average person, lived for 11.1 months, just less than a year. But again, that's the average person. Some patients live better, some patients live less. Obviously, if you have someone who's 85 or 84, that's probably different from someone who is 45 or 60 or 56. But that's kind of to show you what's the average. Also, when it comes to progression, I have patients who I started them on FOLFIRINOX and they've done really well for a very long time. And some of them have progressed within, like the first time I do a CT scan. But really, if you look at the average was 6.8 months. So you really have to do at least a couple of CT scans before you detect progression. If you follow the average progression. But that's what the 11.1 versus 6.8 months came about. Again, the other first line, which was approved 2 years later. That's why I am convinced that now the patient with pancreatic cancer, they should have a decent chance of living more than a year, was with the nab-paclitaxel and gemcitabine. And again, this was compared to gemcitabine, and the median OS was 8.5 months for nab-paclitaxel, and it was 6.7 months for gemcitabine. If you look here, actually, the comparator, the gemcitabine, was almost the same, 6.7 versus 6.8. Now the gemabraxine was 8.5. Now, just to be clear, we are not supposed to compare trials. We are not supposed to compare this trial and this trial and say FOLFIRINOX is better. The reason why, because they allowed sicker patients to be included in the nab-paclitaxel gemcitabine trial as opposed to the FOLFIRINOX. But now we do have trials that have actually looked at them head to head. One of them is called Napoli 3 trial. I'm not going to talk about today, but as time goes on, we will find out really which one is better, the nab-paclitaxel versus FOLFIRINOX. Now, So again, what I talked to you here was first-line treatment. Now here, first-line treatments for BRCA1, 2, and PALB2 mutation. And really, there are 2 trials. I'm not gonna spend so much about digesting them, but I'm gonna show you that in one trial, patients were randomized to get platinum-based treatment for at least 16 weeks, and then randomize them to olaparib versus placebo. And if you look here, the patients randomized to olaparib did better than placebo. So if you decide to treat a patient with BRCA1, BRCA2, or PALB2 mutation with platinum-based treatment like FOLFIRINOX or GemCis, and then here, and then after at least 16 weeks of treatment, you decided to either give them treatment holiday versus olaparib, they should do better with olaparib. But again, when they looked at overall survival, this was not statistically significant because there was some crossover. But the bottom line is, if you compare olaparib to placebo, olaparib is better. Again, myself and many other physicians have so much criticism for this trial, how it was designed. Why would you design something that potentially worked to placebo? To us, that was like a perfect recipe to make something successful. But that's how the trial was designed. That's olaparib. Now, vilaparib, on the other hand, it was either combined or not with GemCis. And I like this design a lot more. So here what they did, they put GemCis, which is platinum-based plus gemcitabine, either with or without vilaparib. And guess what? There was no statistically significant difference. So the conclusion that I take from my clinic, if I have a patient in my clinic, and I know that this patient has either BRCA1, BRCA2, or PALB2 mutation, then my option would be, if I picked FOLFIRINOX, I could afterward to put them on olaparib, or I just do GemCis. If I do GemCis, I do not add vilaparib. I have patients in my clinic who have had BRCA1, have had BRCA2, have had PALB2 mutation. This is more common to see in your practice as opposed to the other molecular alterations. But that's another way to look at first-line treatment if you have BRCA1, BRCA2, or PALB2 mutation. Any questions so far? This is just to show you the difference. This is progression-free survival here, 7.4 versus 3.8 months. And here it was not statistically significant. Now, just maybe I would just quickly touch base on this one. So if you look at the distribution, if you're interested so much, the distribution of BRCA1, BRCA2, PALB2 mutation. So in this trial, 26% had BRCA1, 70% had BRCA2, 4% had PALB2 mutation. Really, maybe this is a good message. When you take care of patients with BRCA2, with pancreatic cancer, you always have to take good family history. And much often you would see pancreas association with prostate and with breast. And that's likely because of the BRCA2. I noticed this quite often in my clinic. And that's where I identify patients with BRCA2 mutations. The ideal thing is you have to send all of them for genetic counseling and for them to have germline testing. But you always have to watch for association between pancreas, breast, and prostate, and obviously other tumors. Okay. Any questions so far?
Doctor, in our country, we didn't have the genetic testing, so we couldn't have any idea about the BRCA1, BRCA2, and BALB2, and also the chemotherapy or immunotherapy, olaparib, vilaparib. It's very expensive here, so we couldn't treat patients with them. So we only depend on the FOLFIRINOX or gemcitabine with Xeloda.
I see. Now, I'm assuming you would have cisplatin gemcitabine, right?
Mm-hmm.
Yeah. So if you have high suspicion, يعني لو عندك مريض أو مريضة وحكوا لك عندهم pancreatic cancer. Again, age, in my experience, I've seen patients with older age or younger age who had BRCA1. But if لو عندك مريض وعنده pancreatic cancer وحكوا لك إنه في عندهم family history breast cancer or prostate cancer, I think لو ما بتقدر تعمل فحص للجينيتك تيست للجيرملاين تيستينج، اتأكد إنه أنت هذول المرضى you treat them with platinum agents. أنت لو تشوف الداتا اللي هون الفيلابرب اللي هو as you said it's expensive وما بتقدر تعطيه لمرضاك بس هون it didn't provide benefits معناها you can do just gymsys and you would have done the right thing for your patients. ولو عملت فولفيريناكس ماشي ولابرب again هذا الكريتيسيزم تبع الستدي هاي انه it was compared to placebo. If you don't give your patients treatment break يعني انت لو كملت التريتمنت معناها what I'm trying to say انه الابرب هون it showed benefit للناس اللي اخذوا treatment break was compared to placebo. فreally يعني missing out BRCA1 BRCA2 PALB2 in my opinion it may not be it's ideal to have it but if you don't miss it just make sure your patients get treated with platinum agent. Yes, cisplatin or oxal.
Also, the difference between olaparib and placebo here is little. So we want to, if you have a study between olaparib and FOLFIRINOX, for example.
ما فهمت السؤال، ممكن تعيد السؤال.
يعني إذا في عندنا دراسة مثلا هلا هون شايفين بين الأولاباريب يعني عملت دراسة مع البلاسيبو، ما نعملت دراسة مثلا مع الفولفيرينوكس.
صح.
يعني يكون مثلا حتى الفرق مثلا نفسه مثلا مثل الأولاباريب، في دراسة يعني بين الأولاباريب مثلا مع الفولفيرينوكس؟
لا ما في، وما بتخيل أي حدا رح يعمل هاي الدراسة.
هلا عفوا الأولاباريب هو بنعطى مينتيننس بعد الفولفيرينوكس.
That's correct. صح. بهاي الستدي he is not polar trial. يعني الآخر بنعطى maintenance. Yes.
maintenance بعد الفولفيرينوكس أو أي كيمو ثاني بالبولو.
لازم يكون في platinum based treatments.
تمام بلاتينيوم
صح. كلامك صح. عشان هيك هاي دراسة حكيت لك it was criticized so much. وفي كثير oncologists يعني they questioned it was well done study don't get me wrong بس يعني the way design انعمل تبعها كان شوي يعني unusual. طيب let's move forward. Second line treatment. هلا if you have a patient who has been treated with first line treatment, okay, you could for those patients treat them with a drug called liposomal irinotecan and 5-FU. أنا ما بعرف لو liposomal irinotecan موجود بسوريا أو ببلاد مختلفة. And I can tell you my own experience, but let's go over the data, but then I'll tell you my own experience. So behind study, they looked for second line agent for many years. ما كان في أي second line agent that showed statistically significant difference in survival, period. فيعني what we have been able to do, or what we used to do, نعطي FOLFIRINOX بعدين نعطي جيمابراكسين، أو نعطي جيمابراكسين بعدين نعطي FOLFIRINOX. This was the pattern. في ناس كانوا بيعطوا FOLFOX والFOLFOX literature كانت mixed. بعد الستدي حكت إنه effective أو بيعمل statistically significant difference وبعد الستديز لا. حتى I think Bilal he and his colleagues they did a meta-analysis على الFOLFIRINOX in second line agent, and he can make few comments about this. But the drug that really was shown to be effective with survival benefit that is statistically significant بالsecond line agent who liposomal irinotecan 5-FU. So if you look here again, the results are not superb. يعني هون بس ال PFS was 3 versus 1.4 يعني 1 months extra. ولو تطلع على median OS was 6 versus 6.2 versus 4.2. And in my clinic, if it's available والمرضى can afford it أو في insurance to help it, لأنه it's expensive. What I usually do is I offer this as second line agent. ليش? I have had at least one case in my clinic who have had really absolutely amazing response to liposomal irinotecan. One patient was sent to me with diffuse ascites after he progressed on FOLFIRINOX and Gemabraxane. And then I put him on liposomal irinotecan. I thought he was going to go to hospice. Put him on liposomal irinotecan 5-FU, and this guy just did really well for almost a year. He was so thankful every time he came to me because he thought he was going to go to hospice. وبعدين he did respond just really nicely to treatment. فعشان هيك if it's available, I think it's not a bad idea to offer this. That's being said, you will get disappointed on many occasions. لأنه most patients will not really respond to liposomal irinotecan. Our response become very transient, very short-lived. But this is really when it comes to second line treatment. Bilal, you want to say any comments about FOLFOX أو بتحب نحكي عنها بعدين؟
لا، بالدراسة اللي عملناها أنا وبسام وزملاء كان الهدف إنه نقارن الدبلت تريتمنت، يعني 5FU مع الأيرينوتيكان أو 5FU مع الأوكساليبلاتين بالمقارنة مع سنجل ايجنت. فالأيرينوتيكان كومبينيشنز ورجت إنه في improved بالأوفر survival وال PFS، بس الأوكساليبلاتين كومبينيشن ما ورجت إنه في improvement over single agent. فبس هذه كان يعني irinotecan بالsecond line irinotecan combinations whether it's irinotecan أو liposomal irinotecan show to improve overall survival or PFS compared to single agent for the second line.
Yeah, so really the message here is في كتير ناس بيعطوا Gemcis first line, Gemabraxane first line, but then when you come to second line, my approach is because if you have done Gemabraxane first line, معناها المريض ممكن he's not in a very good shape to tolerate FOLFIRINOX. That's why you probably have given Gemabraxane. Bad Gemabraxane, your second line agent. If you want to pick between FOLFOX ولا 5FU liposomal irinotecan, I think I would favor 5FU liposomal irinotecan. لأنه بالFOLFOX literature can't mixed. I think 1 or 2 studies showed maybe benefits, some didn't show benefit, and then Bilal and his colleagues they did meta-analysis, and that didn't really prove in the FOLFOX does improve overall survival. So that's just my home message here. But that's being said, in my clinic, a few times I've given patients Gemabraxane, and then I've given them 5FU liposomal irinotecan, and then they continue to do relatively okay. I give them FOLFOX, and guess what? They've responded. So again, on a single patient, things can be different. But if you apply this on a cohort of patients, the one that showed statistical significance improvement is liposomal irinotecan. Any questions? Okay, let's move forward لل subsequent lines of treatment. زي ما حكيت لكم بهداك اللاين اللي فرجيتكم اياه since 2016 after the liposomal irinotecan, every study that was done it only showed improvement by subset of patients. This is a major paper, was published in 2017 New England. What they looked here, they looked at immunotherapy across multiple different malignancies, but the malignancies have to have MSI high tumor. So if you look here, when this paper was published, 6 patients only with pancreatic cancer treated with Pembro, which is a PD-L1 inhibitor. And then 83% بهدول المرضى, they have actually responded. So this was absolutely great news. I mean, when I saw this paper, I was excited in 2017. And then I started to look for patients with MSI high. Again, it's ما راح تلاقي بجوز كثير MSI high pancreatic cancer, بس بعدين هاي كان من multiple trials, but this is the biggest one. هون كان في شوية disappointment. بهاي الترايل 22 patients with pancreatic cancer. واحد بس عنده كان CR, complete response. 3 كان عندهم partial response. So really the response, the overall response rate was 18.2%. So what I'm trying to say here, يعني you can spend so much time إنك أنت تلاقي deficient MMR ولا MSI high pancreatic cancer, وبعدين بالنهاية almost 1 out of 5 patients will respond. فيعني it's just disappointing. لهلا immunotherapy did not really succeed in patients with pancreatic cancer, and I have tried on multiple occasions immunotherapy off-label لمرضى بالpancreatic cancer. I still did not have any successful story. وبرضه dual immunotherapy PD-L1 مع CTLA4 in one trial مع durvalumab tremelimumab, that didn't work. So this is just to give you an idea of immunotherapy is just أكيد أنتم بجوز عم تستخدموه ب lung cancer, it's a terrific drug. Kidney cancer, it's a terrific drug. MSI high colon cancer, it's a terrific drug. But with pancreas cancer, we've only had very, very limited success. Okay, let's talk about track fusion. So we have 2 trials. So واحدة it looked at larotrectinib in track fusion, and if you look here, we only had 1 patient with pancreatic cancer هذا, and من 55 patients. And then here, the study looked at entrectinib they found, I think they had 3 patients with pancreatic cancer. So you look here, 1, 2, 3. So 3 patients had pancreatic cancer. Now here, this patient responded. It was more than 30%. This had partial response. And the 2 patients had partial response. 1 was stable disease. So if you find it, it's actually a great thing. I have 1 patient that I found intract fusion. I gave him intractinib just because I thought, I have more data here, 3 patients. He did respond for almost a year and he had a wonderful life. Again, who are expensive. But if you find someone with intract fusion, I think you'd be missing out the domaptaptium treatment with either larotrectinib or intractinib. Any questions?
لا شكرا.
Okay. Now for NRG1 fusion, this is a trial that looked at patients treated with NRG1 fusion. Again, this is a good target if you find it. I only found it in 1 patient. Unfortunately, that patient was very sick to treat. But patients with NRG1 fusion, they tend to have great responses here. Partial response 42%, 50% stable disease, only 8% progressed. فيعني انت لو عندك 100 مريض عندهم NRG fusion, most of them will either have stable disease or response. This is the KRAS 12C. عشان just to show you, the G12C, it is common more in lung cancer. That's why lung cancer group, they're very happy now with this new target, the target G12C. But if you look at the pancreatic cancer, here it's 4.4, but just to explain this to you, if you take like 100 patients with G12C, most of them would be lung and a minor portion of them would be pancreas. But now if you look at the percentage within the tumor itself, if you look here, the non-small cell lung cancer, it's more common, but if you look at the pancreas, it is almost 1.5%. So really you have to test maybe 100 patients to find 1 to 2 patients with pancreatic cancer with G12C. But that's really the G12C, and this is the proportion. If you look, like for the lung cancer, it's maybe less than 40% here. If you look here, and this is G12V, D, 13D, 12R, and there are others. But if you look at the pancreas C, this is the portion of G12C. The rest will be 13D, 12D. Those are the ones that I see the most in my clinic. And then you can have the R, you can have the others, like I see a lot of V and G. So KRAS is not just 1 mutation, but the G12C is the one that we have target for. And if you look here in lung cancer, we have really interesting data with a drug called sotorasib. And I want to share with you, those are from ASCO GI just last month. Dr. Tony Sapp, he discussed Crystal-1 trial. And if you look for pancreatic cancer, of the patient who had KRAS 12C and treated with a drug called adagrasib, 50% had partial response and 50% had stable disease. So for this patient, for this group, no one progressed on treatment. So again, if it's available and you can find it, that's a very promising data. So after all of what I talked about here, really, what I like to say is progress in the treatment of pancreatic cancer. You can look at things in a very optimistic way or pessimistic way. يعني يا بتكون متفائل أو متشائم. And I بتمنى أن أكون أنا هون. يعني and I see the glass half full, not half empty. بس كل حدا يعني they can look at things from their own perspective. وليش أنا بشوفها half full؟ زي ما حكيت لكم BRCA1 PALB2 5 to 9%, KRAS 12C 1.5%, MSI 1 to 2%, NRG 0.5%, NTRK is 1%. So really, if you add them together, it's not half yet, not 50%, but hopefully we are going to get there sometime. Okay, بعد ما حكيت لكم عن هذه الأشياء, I want to quickly just touch base molecular profiling. ممكن خليني أسأل, بسوريا متواجد molecular profiling, ممكن تعملوا NGS لمرضاكم؟
لا دكتور, في مرة بس بعتنا على أمريكا.
يعني لمرضاكم اللي معهم كانسر لازم هذه ينبعث لبرا, ما تقدر تعمله جوا البلد.
المشكلة so expensive, عم بكلف $2000.
Yeah. Okay, I will quickly just talk here. If you have a tissue, it's the ideal thing to do it really on tissue. Blood, it's not maybe as good as on the tissue. This is just a quick slide to show you. The tissue is better than the blood. I'm not going to go through much details here. This is the same. إنه في لما يكون عندك findings أنت you're more likely to find it بالtissue, but again sometimes بيكون في overlap بين blood والtissue. وفي occasionally some alteration ممكن يكون بالبلد ما تقدر تشوفها بالtissue عشان heterogeneity. بس الconclusion من هاي المحاضرة and I hope it was helpful إنه there has been a progress in the treatment of patients with pancreatic cancer. It's not yet to the degree اللي إحنا بدنا إياها, but there has been progress. Modified FOLFIRINOX is the adjuvant chemotherapy of choice. If you have a patient with pancreatic cancer, really لازم تعطي modified FOLFIRINOX as an adjuvant treatment. If the patient can عمره أو والorgans اللي عنده يعني liver function, kidney function. The advances in the treatment of advanced metastatic pancreatic cancer over the last 5 years has been limited لهدول المرضى اللي حكيت لكم عنهم 10 to 15% with unique molecular alterations. Or ideally, if you can, the patients اللي they can afford the testing, كل حدا فيهم they have to have molecular profiling عشان تطلع ال BRCA1, BRCA2, PALB2, NTRK fusion, NRG1 fusion, microsatellite instability, KRAS G12C, وفي others, في TMB, في others. And if you can do it, لازم تعملهم على biopsy. Okay, this is really the lecture. I hope it was helpful لكم. أنا جاهز لو في عندكم أي سؤال حكيت عنه بالمحاضرة أو ما حكيت عنه بالمحاضرة. I'm happy to answer those questions.
يسلم ايدك محمد, الله يعطيك العافيه. تفضل, مين كان بده يحكي؟
يعطيك العافيه دكتور بلال. انا كنت اسال عن موضوع بس ال choice between the adjuvant and neoadjuvant chemotherapy.
Yeah, this is a great question. I did not talk about this بهالمحاضرة. بس هلا بدي ارجع لهذا الشيء عشان I think that would be a good segue.
والشغله الثانيه هي الراديشن.
Yeah. That's a great question. Just to say. Yeah. هلا شوف. هذا السلايد, if you look, pancreatic cancer, and I like to categorize it into 3 categories: localized, regional, distant. But I want to be more specific. I like to categorize pancreatic cancer as resectable disease, أو بنسميهم إحنا borderline or locally advanced disease, أو metastatic, صح؟ هلا إحنا بهالمحاضرة we covered mostly metastatic disease.
Yes.
We covered the adjuvant اللي already resected. في two areas اللي we did not cover هون اللي هو resectable disease, should we give them neoadjuvant بدل adjuvant؟ والشيء الثاني اللي هو الجروب اللي بالنص هاي اللي هو borderline resectable أو locally advanced. And this is how I would answer your question. هلا when it comes to resectable disease, لهلا no one can claim إنه we know which is better to do, to give neoadjuvant versus adjuvant. Why? Because this has not been done yet and completed in a well-designed randomized trial. And في argument on both sides. If you talk to a surgeon, وأنا بحكي لك, I can give you examples from my own practice. If you talk to a surgeon, ممكن يحكوا لك, we have had patients, the tumor can resectable, والoncologist حكى بده يعطيه neoadjuvant, and guess what? The patient deteriorated, وما قدرنا نعمل له surgery. He would convince you, if the patient had surgery, the patient may have survived. And this may be true for a group of patients. بينما الميديكال oncologist ممكن يحكي هدول المرضى اللي you give them neoadjuvant treatment and they get sick, they deteriorate, هدول على الأغلب ناس they would have not benefited from the surgery to begin with. بس أنا بدي أحكي لك one example بعدين بدي أحكي لك my own opinion and what is the right answer here. I have one patient in my clinic. Let's do it this way. To answer this question, في عنا هلا randomized cooperative true group trial, alliance trial. Behind the trial, they want to answer a specific question that you asked, the resectable disease. should we give neoadjuvant or should we give adjuvant? So patients اللي randomized health trial شو بنعمل فيهم؟ They will be randomized. يعني نعطيهم neoadjuvant first بعدين surgery أو surgery بعدين adjuvant treatment. I put one patient on this trial. We've put many patients, but there's one patient that I put in this trial. Pancreatic cancer. He was randomized neoadjuvant treatment. I gave that patient neoadjuvant treatment, FOLFIRINOX. Guess what? The port got infected with Staph aureus, and then he had infective endocarditis and then septic emboli, and then he passed away. So I'm not saying that this is the right thing. You should not give neoadjuvant treatment. I believe I belong to the group that would advocate to give neoadjuvant treatment as opposed to adjuvant treatment. But to be fair, this has not been answered yet by a randomized clinical trial. Well, clinical trial to randomize this is now ongoing. As much as I favor to give neoadjuvant treatment, the example حكيت لك إياه, this is why sometimes surgeons and other people may be resistant to give neoadjuvant treatment بكون بدهم يعملوا surgery بالأول. بس why and I like to give neoadjuvant as opposed to adjuvant, البيشنت على الأغلب بيكون stronger. بعد السيرجري مرات بيصير عندهم infections, بيكون عندهم leaks, مرات بيكون decline بالperformance status, في منهم بيعملوا منيح. بس the chances of a patient to tolerate treatment قبل السيرجري, in my opinion, seems to be أفضل. بعدين it will help you with patient selection. Sometimes بيكون في أشياء مش واضحة على CT scan, areas in the liver أو areas in the peritoneum. لما بتعطي chemotherapy, those may declare themselves before the patient go to surgery. But this is really my quick answer to your question about neoadjuvant bil-resectable disease. So just the short answer is we don't know if neoadjuvant is better than adjuvant, but we should know this in the future. I am a proponent of, I advocate نعطي treatment after surgery, مش قبل surgery, if this was my patient. Does that answer the resectable disease?
Mm-hmm.
Okay. Now for the borderline and unresectable disease, we treat them exactly like distant disease. So all those patients need to have neoadjuvant treatment. And the choice between FOLFIRINOX or gemabraxine, it really depends on additional patient strong, umro, organ function, kidney function, liver function, but we treat them almost like distant disease. The difference is when you give them treatment, if I try to image them every 2 months, if during that period of time, if cancer shrink or become resectable, then obviously they have to go to surgery. If it does not become resectable, then you just keep going with treatment. Your question is about radiation treatment. Up to my knowledge, most of the trials that were done to look at radiation treatment did not show benefits. So, and especially there's this distinction between Europeans and Americans. Europeans, they for sure ما بيستخدموا radiation بالمرة. الأمريكان occasionally بيستخدموا surgery. أنت بيستخدموا surgery. If you've given chemotherapy وما كان بالمرة في improvement, you could تعطي surgery, تعطي radiation وتشوف if this would help or not. أو sometimes after you finished, after surgery, لو كان في عندك positive margins, أو sometimes extensive lymph node metastases, ممكن تعطي adjuvant radiation. But really the question about adjuvant radiation, I think more evidence suggests lack of benefit as opposed to benefit. That's why if I give it, I only give it occasionally for patients maybe with positive margins. When it comes to neoadjuvant treatment, again, many studies have showed no benefit from neoadjuvant radiation. And if I give it, sometimes just because I've given chemotherapy and chemotherapy is not shrinking this cancer anymore, it's just stable. And it's kind of like last efforts, you know, if chemotherapy is not doing this, who knows, maybe this patient would be long or would be lucky to benefit from radiation. But I do it because I'm desperate. It's not because, you know, I'm excited to do it or because I've seen positive results. Does that make sense?
Thanks.
Yeah, but those are two good questions that you've asked.